That would be fantastic. I mean, with that, I would love to welcome everyone. Good day, and welcome to today's webinar, Medicaid Supports for Family Caregivers. Before we get started, we would like to review a few technical items to make sure that you can interact with us today. The Q&A button. Please click on that button and a window will appear where you may submit a question. We will try to take as many questions as possible at the end of today's webinar. Recording, we just want to let everyone know that we are recording today's session. However, participant lines are muted, so no need to worry about the recording capturing your interaction. We will provide access to the recording on NASHP's website for you to view and share the recording as well as the slides after today's event. And with that, I want to thank you all so very much for joining us today for Medicaid Supports for Family Caregivers webinar. Next slide, please. That's me. My name is Wendy Fox-Grage, and I'm a project director here at NASHP. And I am joined today, next slide, please. I'm joined today by Ronnie Snyder, who is with the John A. Hartford Foundation. I want to thank the John A. Hartford Foundation for their very generous support of and their guidance with NASHP's RAISE Family Caregiver Resource and Dissemination Center. Additionally, I want to thank Ronnie and her colleague, Scott Bain, who are just fantastic and phenomenal project officers. And with that, Ronnie, please take it away.
Thank you, Wendy. You know, right back at you. We're doing some really wonderful work, and it feels good to go to work every day and feel like we're making a difference for people. And so I believe that's why basically all of us are on this webinar today, because we really do believe that it's very important to support family caregivers. And I'm excited to learn more today about Medicaid supports. So as Wendy mentioned, I'm Ronnie Snyder. I am the Vice President for Program at the John A. Hartford Foundation, and I and my colleague Scott Bain work on this project together with the Administration for Community Living, with Wendy and others at NASHP, who you'll hear from, and we're really pleased about that. Next slide, please. Just a couple of words about the John A. Hartford Foundation. We are a private philanthropy. We work nationally, although we're based in New York, and we were established by the family owners of the A&P grocery store back in 1929. So we are not far from 100 years old ourselves. So this is why we love aging. We have funded in aging and health to the order of $625 million in aging and health grants that have been authorized since we opened our aging and health program area in 1982. And we have historically focused very much on building the field of aging experts in medicine, in nursing, in social work and beyond, as well as in testing and replicating models of care and other innovations in the field of aging. Next slide, please. And here's how we are focused now. So our mission is dedicated to improving the care of older adults. This is what we eat, sleep, and breathe every day, professionally speaking. And we do that via these three priority areas. So building age-friendly health systems, supporting family caregivers, that's what we're here to talk about today, and improving serious illness and end-of-life care. You will know, not only because of this image, but also just by virtue of thinking about those three areas, that they are mutually reinforcing, that they are overlapping, and that is very much by design. You really can't have an age-friendly health system if you're not supporting family caregivers themselves, and vice versa. Similarly, if you're not improving serious illness end-of-life care, you're not supporting family caregivers. So these are intentionally overlapping. And next slide, please. I'll just tell you a little bit about our work specific to family caregiving, since that's what we're here to talk about today. Our foundation and a number of others funded a report from the National Academies of Medicine called Families Caring for an Aging America. And the group that came together to work on that report, the experts in the field, came out with a number of recommendations. And one of those across the board is that the focus when we're talking about really supporting older people needs to be not just on person-centered care, which we've been talking about for years and is genuinely very important, but on person and family-centered care. In addition, the support of family caregivers needs to be a really integral part of the nation's responsibility for caring for older people. The report itself had 4 different recommendations, and one of those calls for a national family caregiver strategy. So that first recommendation had 7 sub recommendations to get at that work, and really um, that's part of what this project is about, and this the overall raise work is about. So, you know, the other recommendations reference things like states learning from each other. Once again, here we are today, learning from other states, and talk about a public-private multi-stakeholder innovation fund for research and innovation to accelerate the pace of change. That's another one. And then very importantly, the last of the recommendations themselves talks about in all of the above. So whether we're talking about a national strategy or learning from states, or really thinking through innovation, explicitly addressing families' diversity in accessing care, in assessing, excuse me, caregivers' needs and the supports for them. So next slide, please. Wendy made reference to this particular project, the Raise Family Caregiver Act Advisory Council and the Resource and Dissemination Center that we funded with NASHP and work closely with, and together with the Administration for Community Living as well, is one key way that we're really looking to get caregivers relief. Through the center at NASHP, we're bringing together experts and information that allow the council, the Raise Act Advisory Council, to develop the policy recommendations that they need to. The center itself is a public-facing resource for stakeholders with an interest in family caregiving policy, and also a vehicle, a very important vehicle, to facilitate more rapid dissemination and implementation of the council's recommendations. So as I mentioned, the work's being done by the council, by the Administration for Community Living, by NASHP, and that's an example of the collaboration that's really baked into our DNA at the John A. Hartford Foundation. We aim to work thoughtfully with a whole set of diverse partners to ensure that older adults receive the best care possible, and that includes all of you who are here to learn and listen today. I'm excited to learn myself. Next slide, please. So this is just an image of some of the things that we have funded under our family caregiving portfolio, if you will. All of these grants, everything listed here, specifically respond to that Families Caring for an Aging America recommendations. And again, that's why we're here, and it's why we want to speak with you. So I'm going to stop there. Next slide, please. I'm really excited to hear more today about the NASHP report on Medicaid supports for family caregivers from Kitty, and then really also to hear some specifics from the state of Georgia from Catherine. So thank you so much. Glad to be here with you.
Awesome. Thank you so much, Ronnie. Can we have the next slide? Okay, and now I'm thrilled. As Ronnie said, this is a fantastic private-public partnership that we have with the Hartford Foundation, NASHP, and our partners at ACL. And so I'm thrilled to introduce Greg Link from ACL.
Thank you, Wendy. It's great to be here with everyone to talk about our work. And I would just like to echo what Ronnie said, and as well as what Wendy said. This is truly exciting work. In my 30 plus years in working in the field of aging, I don't think I've had the opportunity to work on a project that is quite as far-reaching, but also as dynamic and as exciting. And when you get to do it with partners like the John A. Hartford Foundation and NASHP, it makes for some really, really fun and stimulating discussions. And we also believe very, very strongly in the work that we're doing. What I want to do with the time that I have is sort of further ground this webinar and its focus on Medicaid and family caregiving. I want to further ground that message in the requirements of the RAISE Act and let you know how this information that will be presented today will fit into what the Family Caregiving Advisory Council is doing more broadly in the development of the National Caregiving Strategy. So if we can go to the next slide, please. So the RAISE Act, RAISE is an acronym that stands for Recognize, Assist, Include, Support, and Engage Family Caregivers Act, became law in January of 2018. And the RAISE Act has three key elements to it. One of them is the establishment of a Family Caregiving Advisory Council. The second element is the development of an initial report to Congress, and I'm going to get into a little bit of the details of each one of these elements. And then the third, and perhaps the most important, is the development of a national family caregiving strategy. We are well underway in the first two bullets, and we are beginning to lay the groundwork now for the development of the national caregiving strategy, which will begin early next year. The current RAISE Act has a sunset now of 2022. Congress extended that sunset by 1 year with the reauthorization of the Older Americans Act this past April, in which they extended the sunset deadline by 1 year to give us additional time to do this work because of its complexity and the depth. We're very appreciative of the additional time to really do a thoughtful and thorough job, particularly on the national caregiving strategy. If we could go to the next slide, please. Before I delve into the three specifics, though, I do want to tell you or share with you a bit of the context that we're working in. The RAISE Act defines the family caregiver as an adult family member or other individual who has a significant relationship with and who provides a broad range of assistance to an individual with a chronic or other health condition, disability, or functional limitation. So in this regard, it's important to note that as we look at family caregiving through the perspective of the council and through what the RAISE Act is calling for, we are looking at it from a lifespan approach. So it is caregivers of individuals of any age, from 0 to the oldest of old, with any number of chronic long-term conditions or special needs. And we truly are taking a lifespan approach in the work, and that lifespan approach and the cross-disability perspective is definitely reflected in the makeup of our Family Caregiving Advisory Council and how we're going about our work in terms of outreach, public input, and the like. Next slide, please. So the RAISE Act called for the establishment of a Family Caregiving Advisory Council, and its main purpose is to advise and provide recommendations, including best practices, to the Secretary, and that's the Secretary of Health and Human Services at the federal level, on recognizing and supporting family caregivers. And so the Family Caregiving Advisory Council consists of a slate of ex officio federal members, of whom the administrator of ACL, the administrator of CMS, and the VA secretary or their designee are required federal participants. And then we have a number of other participants from across federal government, many from within the Department of Health and Human Services, but as well as other departments across government that may have work that touches on family caregiving, that may have programs or initiatives that somehow support families, whether directly or indirectly. The council is also made up of up to 15 non-voting members. And the act is very specific about the backgrounds and the constituencies that these up to 15 non-federal voting members come from. They have to represent veterans, older people, people with disabilities, family caregivers, people that represent paraprofessionals, healthcare, employers, the like. So we have 15 non-federal members who, through a public call for nominations, were selected by the HHS Secretary to become the non-federal members of the Family Caregiving Advisory Council. The council, in its first meeting, its first convening back in August of 2019, divided themselves into 3 working subcommittees. They meet very regularly on a monthly basis and are very, very focused on, first of all, bringing this initial report to Congress to fruition, and then later will turn their attention to the development of the national caregiving strategy. And in a moment, I'll share with you some links where you can go to find out more about the work of the council and what they've been up to so far. Next slide, please. So our first task, once we had the Family Caregiving Advisory Council convened, was to begin developing the initial report to Congress. And again, the RAISE Act is very specific about what that report is to include. And so we are working hand in hand with the members of the Advisory Council to develop this report. We're first looking at conducting an assessment and inventory of federally funded efforts to recognize and support family caregivers. Indeed, this was a cross-government effort, and we're bringing that piece of the report to a close right now. The report will also, as most reports do, include recommendations to improve and better coordinate federal programs and activities, including those with state programs. And we're also going to be looking at delivering how can we improve the delivery of programs and services. We've done an extensive look at to identify some of the financial health and other challenges faced by family caregivers. We did this through a very, very comprehensive and thorough literature search, a review of research that has come before, but we also conducted a request for information in late 2019, early 2020, that garnered more than 1,600 individual responses from folks around the country, many of whom, a vast majority of whom, were family caregivers themselves. All of that information is being used to build out the report that we're developing with real-time and current information, but a lot of that information will also go into helping inform the development of the National Caregiving Strategy. And then another key aspect of this report is a look at the impact of family caregiving on Medicare, Medicaid, and other federal programs. And today we are looking at what's that Medicaid piece of family caregiving and how Medicaid supports family caregiving and some opportunities and activities that are currently going on. Next slide, please. The second deliverable, which we will begin working on after the initial report to Congress is developed, will be the construction of the National Family Caregiving Strategy. And that work is really to be done jointly by the federal agencies that comprise the Family Caregiving Advisory Council, as well as with the non-federal members. And that national strategy is to identify actions that can be taken at the federal, state, local, community, and other levels, including health and long-term services providers, to better recognize and support family caregivers. And so because this goes beyond just what the federal government can do, but looks at what states can do and communities can do, we really are looking at the development of a national strategy, one in which not every sector will be involved in every activity, but when we all think about it holistically, we are working better on a national level to support family caregivers. That strategy will be reflective of the diverse needs of family caregivers. We've spent some considerable time looking at family caregiving across diverse populations and cultures. And it will be made available, delivered to Congress and available online. And that national strategy, per the RAISE Act, is to cover such topics as family caregiver assessment, respite, information, education for family caregivers, financial security, and workplace supports. It will be very, very comprehensive. It will also be a living document. That strategy is to be updated on a regular basis every 1.5 to 2 years. And so it's not something that will be a one and done. It will continue to grow and evolve as we make progress as a nation to better support family caregivers. Next slide, please. So we have had a lot of activity since getting underway in implementing the RAISE Act. We have had a number of full meetings of the Family Caregiving Advisory Council, all of which have been open to the public. You'll see that we had our inaugural meeting August 28th and 29th of 2019 here in Washington, D.C. That was the only meeting that has occurred face-to-face because of the COVID-19 pandemic. We switched everything to virtual. We had a February meeting that was virtual, that was pre-pandemic. Everything that we have done after has been in a virtual environment. And we're planning the 6th meeting of the Family Caregiving Advisory Council for next week on Wednesday from 12:30 to 4:30 p.m. Eastern Time. There is more information on the ACL website, and I'll give you that link here in just a minute. As I had mentioned also, we had done that request for information from December 2019 to February of 2020, 1,613 responses, 75% of which came from family caregivers. We really believe that we heard loud and clear from family caregivers what their concerns are, what their challenges are, what they need, and recommendations that they have. I can tell you that some of the entries and some of the submissions to that were truly moving and many heartbreaking, but they are going to be driving the development of that national strategy. Next slide, please. So as you've probably gathered, we have a really kind of a cool and amazing team working on this. At ACL, we were so grateful to the John A. Hartford Foundation for approaching us to ask us how could they support the work, knowing that the comprehensiveness of the RAISE Act and the fact that resources available for implementation were relatively limited. I can tell you that without the support of the John A. Hartford Foundation, we wouldn't be able to do the technical assistance and the dissemination activities that is a key part of the RAISE Act. And then, of course, we have the National Academy for State Health Policy to work with. And so it is quite an exciting process. Next slide, please. So we do have acl.gov has a web page dedicated to our activities on the RAISE Act. This is an ever evolving web page. Everything that we have done so far is posted on this website. The links to the meetings, which are open to the public, you do not need to register ahead of time. Everything is posted on this acl.gov/RAISE website, as well as you can also link to a companion effort that we have going on regarding supporting grandparents raising grandchildren. The two initiatives, while separate, are inextricably linked, and we expect that those two projects will begin speaking more closely with one another in the coming months. Next slide, please. Here's my contact information if anyone has any questions, but with that, I will turn it back to Wendy.
Great. Thank you so much, Greg. We are so, it's just such a pleasure working with both you and Ronnie and your teams. Speaking of teams, if we can have the next slide, I am thrilled to introduce my colleague, Kitty Purington, who's a senior program director, to talk about a new report that we just issued, our Medicaid report, and to talk about an exciting new opportunity for states. So with that, Kitty, you're on.
Good afternoon, and of course I had forgotten to unmute myself. Good afternoon, everyone. My name is Kitty Purington, and I'm a Senior Program Director at the National Academy for State Health Policy. And next slide, please. For those of you not familiar with NASHP, we are a nonprofit, nonpartisan organization. We were formed close to 35 years ago, and our work is really to support state policymakers in their efforts to improve state health policy. Our work is really shaped and informed by an academy of state policymakers from states, diverse states across the country. We work with state policymakers also across state government and on issues related to Medicaid, access, coverage, public health, just to name a few. Next slide, please. And as you have heard, NASHP is extremely fortunate to have the support of the John A. Hartford Foundation, funding our work to support the RAISE Act, the RAISE Act Council, and also ACL in their great efforts to develop a national strategy on family caregiving. Next slide, please. So I'm going to be speaking today about some of the work that NASHP has been doing to support state policymakers in their efforts to develop strategies through Medicaid to support family caregivers. And NASHP recently released a brief on this topic. That brief is available on NASHP's website, and we have also shared the link to that report in the chat box. Medicaid, as many of us know, is funded by individual states and the federal government. And this, of course, results in highly diverse state programs. We really have 50 different state programs and shaped by a lot of different factors that are very particular to the political, budgetary, and even cultural landscape of those individual states. So, you know, Medicaid, as they say, if you've seen one state program, you've seen one state program. Next slide, please. So we might want to actually rephrase this or reframe this slide as why are family caregivers important to states? We know that long-term care, long-term services and supports are an enormous and growing cost driver in state budgets. States spend close to $200 billion through state Medicaid programs on services and supports for individuals with long-term care needs. And as we all know, this number is expected to grow as the country continues to age. Next slide, please. So states are increasingly interested in how to support more older adults and people with disabilities in the community through home and community-based services as opposed to nursing facility services. And this trend is seen in how states are allocating their budget dollars. It's also been a critical theme in the past few months as states have struggled to create those safe services and systems for older adults who are at particular risk for COVID. And for many state policymakers, the flexibilities that they've been able to institute in the past few months in response to COVID have really highlighted both how important family caregivers are in this whole equation of supporting people in their homes and communities, but also what lessons can be learned from the policy strategies that innovative states are developing over the course of the past few months, and how these different strategies can assist states to better support Medicaid beneficiaries and their family caregivers in the future. So I think it is in a lot of ways really a time of enormous innovation, enormous challenge, and a lot of states are thinking about how do we reshape the services and supports that we provide to older adults and people with disabilities so that people are safer, people are in the community, people can be more effectively supported by their families. Next slide, please. So as I mentioned, NASHP recently published a brief on how state Medicaid programs support Medicaid enrollees and their family and their caregivers using a range of Medicaid authorities. So I'm going to briefly and at a pretty high level talk about how these strategies, how states support family caregivers and flag a few innovative programs. But I also really do encourage folks to take a look at the brief for additional detail and more information on how states are not just the what, but the how of the policy underpinnings that states are using to support these programs. I wanted to first highlight the range of options available. So, in addition to home and community-based waivers, 1115 demonstration waivers, managed care, all vehicles, authorities that states have used for many years to support innovative programs for people, older people and people with disabilities. States are also increasingly using state plan options such as the 1915I, 1915J, and 1915K to build in state options that can support individuals and their families. And these options really provide all sorts of different degrees of flexibility in terms of services, eligibility, and cost containment. Next slide, please. So using these various policy strategies, states are offering services first and foremost to the Medicaid enrollee. They are doing this by creating services that also engage the family caregiver. They can reimburse family caregivers directly for providing services. States may provide supports to the family caregiver, such as training and education that indirectly support the Medicaid enrollee. States can also offer care coordination that can enhance access and address enrollee and family needs more comprehensively through things like transportation, food insecurity, and other social determinants of health issues. Next slide, please. So this slide does have a lot of detail that I'm not going to walk through, but does provide some comparative information on the state plan options that states are using to support a whole range of innovations. Then, as I mentioned, the 1915I, J, and K options in particular can be used to provide home and community-based services within a state plan, including self-directed care options that allow states to reimburse family caregivers for services provided to Medicaid enrollees under certain circumstances. And I think that's another authority that states are using with increasing frequency and are interested in exploring. These state plan options differ in a number of important features, such as eligibility, how benefits can be structured, how these benefits interact with other Medicaid services, and other requirements. Next slide, please. And again, as I mentioned, 1915C and 1115 waivers are used to pay for services that can also support family caregivers and their Medicaid enrollees with significant needs. 1915C in particular is increasingly used in conjunction with Medicaid managed care. And this allows states to really tailor benefits to support people outside of institutional settings and to expand access to the Medicaid program for individuals who would otherwise not qualify for coverage. Next slide, please. So NASHP's brief found that states are using these authorities as in a number of really innovative ways. Washington State has developed outreach to inform enrollees and caregivers about available caregiver supports. And that outreach effort included partnering with hospitals, employers, and community-based organizations, as well as partnerships with their local area agencies on aging. Utah provides training to help caregivers better meet the needs of their loved ones, and its New Choices 1915C waiver covers training on care regimens or the use of equipment for unpaid family caregivers. Tennessee's caregiver assessment helps to identify and address relevant caregiver needs as part of care planning for the enrollee. Their Choices and LTSS program requires Medicaid managed care organizations to conduct a formal assessment of an enrollee's caregiver and to include actions that include caregiver needs. In Florida, that state is requiring MCOs to provide behavioral health services for family caregivers. It's Florida Children's Medical Services provides enhanced benefits to enrolled children that also support their family caregivers, including behavioral health services. So, this is just a flavor of the kinds of things that we're seeing, but we also know that state policymakers are endlessly creative problem solvers. So we anticipate that there are other examples out there, and that is another piece of the work that we'll be doing, is to continuing to look at what states are doing and to capture and share those innovations with other states. Next slide, please. We also spoke with many state policymakers about how the federal government can help states implement family caregiver strategies. And we see a role for the federal government in helping to share and spread successful state innovations, to support those leading states who are already doing this great work, to help them refine and improve their efforts, for instance, with technical assistance and additional flexibilities. To help states identify ways to gather data on family caregiving, to assist in really quantifying these issues and quantifying this population, and also conducting a comprehensive effort to identify all the different ways that states are supporting family caregivers, so that we can begin to get a better understanding of what is possible and what can be replicated. Next slide, please. So some of the key takeaways from NASHP's research, certainly we know that family caregivers play a really critical role in states' efforts to balance Medicaid, to balance its long-term services and support systems, so that more individuals with disabilities and older adults can remain in the home and in the community. They have been shown to offset the cost of personal care services and have the potential to delay institutional care and prevent avoidable hospitalizations. We also know that family caregivers need additional supports in order to keep fulfilling this role, and that through Medicaid, there are a lot of different forms this support can take. Next slide, please. So some of the other innovations and activities that we learned from our research about how states are moving this forward in other ways include partnering with AAAs on outreach, providing guidance on caregiver assessments, looking at nurse delegation and other scope of practice issues. And finally, as I mentioned previously, states have really embraced the flexibilities available to them through the emergency, Appendix K emergency waivers, to build out new ways to support people with complex needs and their families. So things like telehealth, additional avenues for consumer-directed care, and payment to family caregivers, using Lyft and Uber and DoorDash and other things to overcome just the daily challenges of addressing basic needs, and a range of other strategies. It continues to evolve. So of course, many of these innovations are temporary, but we also anticipate that many states will be looking at these changes as fertile ground for future and possibly permanent state strategies and policies. So this actually I wanted to mention, will be the focus of an upcoming state policy academy that NASHP will convening. We will be providing states with resources, including some small grant funding directly to states to work on their own key priorities related to Medicaid and family caregiving. So we strongly encourage you and would love to have you check out our NASHP website in the coming weeks. We anticipate releasing an RFP for participation in this institute in mid-December. So we're very excited to explore these issues more comprehensively with individual states. I just want to say thank you to the state officials who helped us with this work, including Colorado, Florida, Georgia, Idaho, North Carolina, Tennessee, Utah, and Washington. We also worked closely with NASHP's own Long-Term Care Steering Committee, who always provides excellent guidance to our work. Would love to thank Greg and the other staff at the Administration for Community Living. And finally, thank you to Ronnie Snyder, Scott Bain, and to the John A. Hartford Foundation for really making all of this work possible. So back to you, Wendy.
Great, thank you, Kitty. And also adding to our thank yous, I just want to acknowledge our colleagues, Neva, Salam, and Paige for their great work on that exciting paper that we've just released on Medicaid family caregiver supports, and we hope you all will read that. Next slide, please. And the next slide. Fantastic. And so it's my honor to introduce our next speaker, Catherine Ivey, who is with the Georgia Department of Community Health. Catherine, it's all yours.
Thank you, Wendy. It's actually my honor to be here, and I appreciate your having me today. We've heard from Kitty about what other states are doing. We heard from Greg when he said that it's very important that we look at the diverse needs of caregivers. And so I want to take you down a path of what Georgia has done over the past few years in response to caregiver needs. And so my name is Catherine Ivey. I'm with the Division of Medical Assistance Plans, which includes Medicaid, for the Georgia Department of Community Health. Next slide, please. Thank you. This is our mission statement, access to affordable quality health care. Next slide, please. And our purpose is to reshape or shape the future of a healthy Georgia. And so if you give me the next slide, please. Thank you. My title in Georgia is Deputy Director of Medicaid, and in specific, Service Administration and Delivery. And under that, in my purview, is managed care and also a group of long-term services and supports in Georgia that we provide through 1915C waiver programs. In Georgia, about 3/4 of our population is in fact enrolled in managed care, but not in Medicaid, what we call our age-blind and disabled population. We have not included that population in managed care in Georgia. We still operate several 1915C waiver programs, and the nice thing about all of those waiver programs, I think it's nice anyway, is that they're relatively old, some very old waiver programs, which have just evolved over time. So when we talk about diverse needs, I do want to take us down the path for just a minute about the different kinds of caregiver requests and conversations that we've had over the years and what that has evolved into in terms of service delivery. So we have 2 waiver programs in Georgia that are really devoted to serving folks with intellectual and developmental disabilities. The one called the New Options Waiver Program is a waiver program that is designed for individuals who live primarily with family members in family homes. We have a very large elderly and disabled waiver program for older and disabled adults, and we operate a somewhat smaller program for folks with physical disabilities and or traumatic brain injury called the Independent Care Waiver Program. Next slide, please. Thank you. And so to Greg's point, I'm going to talk about what we've done in those various waiver programs in chronological order by when it came to us, when we heard about it from family members in particular, and what we developed in response to that. And so We provided over time targeted support to parents of disabled adults, family caregivers of older adults, and then spouses and family members of younger adults with some pretty serious physical disabilities. Next slide, please. Thank you. In particular, caregivers of people with intellectual and developmental disabilities. One of the nice things about 1915C waiver programs is that when you do anything with them to change them, you have to go out in the public, in the users of those waiver programs and ask, what's working for you, what's not working for you. And so over time, we had developed a pretty sophisticated behavior service program for people with intellectual and developmental disabilities, but it was too sophisticated. We would hear family caregivers and formal caregivers also, folks who worked in group homes, folks who worked in family homes, who would say, you know, those behavior intervention plans that you all pay to have created, they are really good, but sometimes we just don't quite understand them. They're very sophisticated, they're very professionally written, but they're a challenge for us. And so what we did in 2016 is we developed another level of behavior support services, which is very specifically designed to support caregivers. So the whole purpose of it is to provide teaching, practice skills, on-site demonstration of behavior intervention. And so a trained clinician goes into the family's home and shows them how to implement that, what could be a really complicated behavior intervention plan. And so that was an evolution in our intellectual and developmental disabilities waiver that came directly from mostly parent caregivers. Next slide, please. Then similarly, we listened to folks, family caregivers of people with significant physical disabilities. And what we heard a lot was that my family member, my husband, my sister, whomever, requires round-the-clock skilled nursing care. My husband requires mechanical ventilation for breathing, and I can't just leave him with anyone. And so we expanded our nursing services that were already available in the waiver, but sort of in a home health model, so that they were delivered per visit versus by any particular period of time. And we expanded those to become hourly nursing services, specifically for the purpose of allowing a caregiver to get some relief. If that caregiver knew that the tasks required for her spouse or whomever were really of a skilled nature, we can provide a nurse for some number of hours to deliver that and to provide caregiver relief. Next slide, please. I wanted to really finish up with what I think most of the participants on this webinar would be interested in. And it was really designed fairly recently in 2019 for caregivers of older adults. What we heard from caregivers of older adults was that they'd left the workforce. They had done that quite lovingly and willingly to provide care for their family member, but they really needed a lot more help and support than they were getting. So we looked around. We were approached by an organization that does this in other states. We spoke to them for quite a period of time. We do what all Medicaid agencies do, and that's that we reached out to other Medicaid agencies who had implemented this program a while back to find out what was working and what wasn't. And then we implemented in 2019 through a waiver amendment, structured family caregiving. Specifically, we had some goals for that particular service, and they were all around support goals. So we heard family caregivers saying that sometimes they just needed some health education. They didn't feel like it was important enough to pick up the phone and call the primary care physician, for example, but if they could just ask somebody, that would be terrific. We also knew that they needed financial support because they told us repeatedly that they needed some financial support and assistance. And then there was the emotional support part as well. And you all have heard it, just like we did, that it's a very isolating job. It's a lovely job. It's a For those of you who have been or are family caregivers, as I have been, you know that you do that with love and devotion, but it can be a lonely position to be in. And so we really went down this path of trying to provide all of those in a meaningful way in that service called structured family caregiving. And so in terms of staffing, we enroll agencies for structured family caregiving. And those agencies have to have experience in health education or in service delivery to older adults and disabled adults. They offer monthly contacts at a minimum through health coaches. And we also required that they have an RN available for medical consultation. So that registered nurse, who has to be a registered nurse in the state of Georgia, should that nurse need to go and make an on-site visit, has to be able to provide consultation to the health coaches who are non-nurses, or consultation if need be to family members, or provide a liaison role between the family member and a primary care physician or a specialist physician or other health professional. It offers a caregiver stipend. Now, like many states, we in Georgia are always financially strapped, and so we had to create a program that was going to be budget neutral. And the way that we did that was we calculated the amount that we would reimburse for a caregiver, a formal caregiver from an agency to deliver 5 hours or more of support to an older adult or disabled adult in the home. And that's the way we set the rate. We developed a per diem rate so that it allowed maximum flexibility. And we put a 60% requirement on that per diem rate as the stipend to the family. And so ultimately, it supports not only the professional services that the agency is delivering and providing, but it also supports the family caregiver through a small stipend. We do require daily caregiver notes to be submitted, and to that end, all providers have to demonstrate to the state prior to enrollment that they have secure technology for web-based submission of those notes. Now, the notes don't have to be anything fancy at all, but we feel like that's the best way for us to stay in touch with the family caregiver and to try and divert anything that might become a crisis down the road a bit later. Now, here's what we didn't want to do, and I did want to make a point of letting y'all know that at the same time, we were undergoing really a reformation or a recreation of all of our case management in Georgia. We offered online web-based platform training for all case managers in all of our 1915C waiver programs to make absolutely certain that they were starting from the same level set information about case management itself. So we didn't want to exclude them from the relationship that they had with the clients that they were serving already. So we put in a component in structured family caregiving that requires that relationship building and requires the interplay between the waiver case manager and the health coach in the structured family caregiving model. One of the things that they have to do is the waiver case manager has to have access to that web-based platform where the caregiver submits notes on a daily basis. Knowing that a lot of caregivers may not have a comfort level with electronic submission of notes, we also require that the structured family caregiver agency have an alternate method for them to submit notes. It can be a fax machine, that's perfectly fine. It can be as low-tech as the caregiver wishes to have. But they do have to be able to provide a web-based model as well. Every 6 months at a minimum, the waiver case manager and the health coach are required to visit the member and the caregiver together so that they are seen as a team versus as one or the other with no contact with each other. And so that was important to us. And that I will tell you has worked really very well. Next slide, please. Thank you. So I just wanted to end by saying that the evolutions that we have made on behalf of family caregivers have really been all about listening to what the various caregivers have told us. And we found it not only to be individual to the caregiver and to the waiver participant, but we found it also to be very individual to the population that the waiver serves. And you could see that throughout the slide presentation. So I would just end by saying that our evolution has been really all about listening to what caregivers need and then trying to create that within a Medicaid waiver framework. Thank you.
Thank you so much, Catherine. Really appreciate that. Can we have the next slide? Fantastic. So it is Q&A time. We have just a little bit of time. Just to remind you, please type your questions into, we're going to actually not make it the chat box, but if you can type it into the Q&A button, that would be fantastic. I'm going to go ahead and take the first couple of questions. So we've been asked, will the recording of this webinar and the slides be available and where? And the answer is yes, they will be. Please check back next week on the NASHP website and we will post those. Another question, what does MCO stand for? It stands for Managed Care Organization. The next question, Catherine, you might want to take a stab at this as well as Greg, because I know at both federal and state levels, you've come across this. It was really our first question from Allison. I work on health policy related to children and youth with special healthcare needs. I see a great deal of overlap in family caregiving with youth as well as older adults. How can we work together closely on both state and federal policies to support family caregivers? And Greg, if you can talk about it, maybe the RAISE Act, how they're taking a broad view, as well as Catherine, I know you've really been listening to the family caregivers who are caring for all different populations. So with that, Greg and Catherine.
Sure, happy to take a first stab at that question. So as I had mentioned at the start of my remarks, we are, the RAISE Act requires us to look at family caregiving as a lifespan issue. And so we are looking at the families who are caring for children with special needs as well as adults with disabilities across the age and disability spectrum. You know, one of the best ways I think to get involved now is to tune into the meetings of the council when they occur. Although they're in a virtual format, just exactly like this meeting is, there is an open chat function where you can provide input and feedback to what the council is discussing. All of that information is captured real time. We have incorporated many of the notes and questions and feedback that people have offered from past meetings into the work that we're doing. I would say again that later on, as we begin developing the national strategy, that too will be done in a very open and public way. And there would be further opportunities to provide, you know, suggestions for how federal and state can work together. Again, once the national strategy comes out, we fully expect that there will be significant opportunities for states to identify areas where they can undertake activities that will lead towards an outcome in any number of the different priority areas that the council is considering. And a lot of that will require partnership with federal programs as well. So I would just say keep monitoring, you know, the activities of the council. I think the report will be very telling when it comes out. The recommendations that we are going to be voting, that the council will be voting to adopt on Wednesday of next week, deal a great, you know, in quite a bit. At least one of them I know speaks directly to working with state and federal together, but there may be other opportunities in other areas. So, Catherine?
Yes, thank you, Greg. Well, just as Kitty mentioned, when you've seen one state Medicaid program, you've seen one state Medicaid program. That's an old adage, but it couldn't be truer. And so what I think we all do a good job of, I certainly know I have depended a lot on my counterparts in other states to just give me ideas. Just yesterday, many of us were on a state Medicaid directors meeting, and we get our best ideas from each other, to be honest with you. And where the ideas originate, exactly as I was talking about earlier, is with the caregivers themselves. And like you, I think particularly when you work across populations, you know that caregiving is caregiving. There are certainly nuances depending upon the population, but it's all at the end of the day about caregiving. And so because of the population nuances, that's why I think it's so important to listen to the caregivers, and then to look across states, because Medicaid it's a funny thing, and it depends upon what box of Medicaid you're trying to fund services through as to how you approach it. So I'll tell anybody and unashamedly that I look at other states' Medicaid waivers all the time, just to see what creative services they've come up with, what authorities they've used, and how they did it, how they priced it. And so I think that's a good thing to do. We have, I think it was maybe Kitty who mentioned earlier, we've had a lot of wonderful and unique opportunities. As bad as the COVID public health emergency has been, CMS has been delightfully flexible with regard to what we could do. And so one of the first things we did in Georgia, in recognition that if you've got a very medically fragile child, you don't want a non-family member coming into your house, and you certainly don't want 3 or 4 of them coming into your house every week. So we opened up families to be able to be hired by the agency that they had previously received services from. At the same time, we allowed that agency also to be able to bill under a retainer payment for the staff member. So, and it couldn't be done concurrently, but agencies have gotten very creative with toggling. So they might pay that staff member a retainer payment to just basically not go get another job, to stay on board for a while. And then when that wasn't available any longer, they hired the family member to deliver care. They might have hired the family member right off the bat, but it's really given us some great lessons about ways to expand, as you all know, an ever-shrinking workforce. So the lessons learned have been really good. But just reach out and ask other folks what they need and what they've done before that's worked.
Great. This next question is about Medicaid waiver waiting lists. And the question is, Medicaid waiver programs are so helpful, but there are so many on the wait list. What would need to happen in order to serve all the caregivers that need these services, and what's being done to move toward this ideal outcome?
You know, that is the question that's haunted us all for the past at least 22 years or so. Medicaid waiver programs are funded, at least in part, through state government. And so they can only expand insofar as each state legislature has appropriated the state funding. And that depends upon the waiver program, it depends upon the year, it depends upon the overall budget and economic climate. And so that's been the cause of the waiver wait lists. I think, as somebody mentioned earlier, that's a reason why many states have moved toward the use of managed care for long-term supports and services, because it allows a little bit more flexibility, sometimes a little bit more funding because of the capitated rate. I know that there are pros and cons to it, and folks will argue both sides of that coin. But other than just infusing a lot more money, I tell folks all the time, we're just going to have wait lists in these capped waivers.
And I just wanted to mention also that there was a recent report from UMass Boston, the Leading Age Center, on how, some of the initial efforts that states have taken to develop social insurance programs so that Medicaid isn't the sole funder of a lot of these services. And that might be something that we start to see because Medicaid programs and state budgets are getting really stretched, especially now. So that may be something that we start to see more of in the future, is engaging the private sector.
Fantastic. I want to thank all of our speakers today, as well as our participants. I know at one point we had over 200 participants, and I have a favorite ask of everybody who's on the Zoom call. Can you stay put? We are going to have a survey right at the end of this webinar, because we really, so if you can fill out our survey, we really value your feedback. We're going to have a specific question for state health policymakers. We really want your feedback on our evaluation about your state's family caregiver policy priorities so that we can better meet your needs. So with that, thank you, thank you, thank you. We appreciate it, and everybody have a wonderful day.
Thank you.
Thank you.